Every beat of the human heart works against a continuous mechanical friction known as vascular resistance, the opposing force that must be overcome to drive blood through the circulatory system. This relationship is defined by the bedrock equation of cardiovascular physiology. Mean arterial pressure equals cardiac output multiplied by total peripheral resistance. While the heart generates the output, total peripheral resistance acts as the primary modifiable switch for adjusting systemic blood pressure. This resistance is split between two distinct networks. The systemic circulation generates systemic vascular resistance, or SVR, for the body, while the lungs operate under a separate set of rules to generate pulmonary vascular resistance, or PVR. The body manipulates three physical variables to control this resistance: the length of the vessel, the viscosity of the blood, and the radius of the vessel. Of these, the vessel radius is the most sensitive regulator of flow. The relationship between radius and resistance is nonlinear. In biological systems, resistance is inversely proportional to the fourth power of the vessel's radius. Because of that exponent, even a minor change in width has an outsized impact. Reducing a blood vessel's diameter by half restricts the flow volume to just 1/16 of its previous capacity. In a physical model, constricting a tube's radius by 50% causes the total volume of fluid passing through to plummet by nearly 94%. This exponential relationship allows the body to maintain cardiovascular stability through microscopic tweaks to vessel size, rather than needing to rebuild the vascular network to accommodate changes in demand. These microscopic diameter changes are executed by specific biological hardware within the vessel wall. To isolate the mechanisms of resistance, we must dissect the wall into its three structural layers. The outermost layer, the Tunica Adventitia, is a strong fibrous shield that prevents high-pressure rupture. The innermost layer, the Tunica Intima, is a delicate endothelial lining that secretes local signaling molecules like nitric oxide to communicate with the surrounding tissue. Positioned between them is the Tunica Media. This layer contains the specific mechanical components required to actively maintain and adjust systemic blood pressure. The Tunica Media is composed of elastic connective tissue and smooth muscle. While the elastic fibers help maintain pressure during cardiac diastole, the smooth muscle provides the active force necessary to manipulate the vessel's radius. This tissue functions as unitary smooth muscle. Individual cells are linked by gap junctions, which allows entire segments of the vessel to respond to a single signal and constrict as a coordinated unit. By utilizing the Tunica Media, the central nervous system can mechanically squeeze or relax the vascular network to route blood flow according to the body's needs. The primary control signal for this smooth muscle comes from the sympathetic nervous system, with neurons synapsing directly onto the vascular wall. For immediate adjustments, these neurons release norepinephrine onto alpha-1 and alpha-2 adrenergic receptors. This binding triggers the smooth muscle to contract, leading to rapid vasoconstriction. Long-term regulation is managed through the hormonal cascade of the renin-angiotensin-aldosterone system, or RAS. The signaling molecule angiotensin II specifically targets the smooth muscle of critical pathways, such as the arterioles of the nephrons, to increase their tone and raise systemic resistance. Beyond the vessel walls, resistance is also influenced by the physical properties of the blood itself. This factor is blood viscosity. In conditions like polycythemia, an abnormally high concentration of red blood cells creates a bottleneck that increases friction and resistance. Conversely, thinner anemic blood flows more readily, reducing the resistance within the circuit. Systemic vascular resistance is therefore the result of a constant interplay between neural adrenaline, hormonal regulation, and the physical thickness of the blood. These systemic rules do not apply to the lungs. Pulmonary vascular resistance is governed by a separate set of mechanical requirements. While resistance in the lungs is still centered in small arterioles and precapillaries, these vessels are not primarily driven by receptor-mediated commands from the central nervous system.
Instead, pulmonary resistance is dictated by the physical mechanics of breathing, which alters the vessel diameter through direct tissue inflation and deflation. This relationship is visualized by the pulmonary U-curve. Total resistance in the lungs is the sum of the forces acting on two specific groups of vessels, the alveolar and the extraalveolar. At high volumes, during inspiration, the expanding alveoli physically stretch and crush the adjacent alveolar vessels. This mechanical compression significantly increases the resistance on the right side of the curve. During forced expiration, at low lung volumes, the lung tissue loses the radial traction that normally keeps vessels open. Without this outward pull, the larger extraalveolar vessels narrow and collapse, causing resistance to spike on the left side of the curve. Total pulmonary resistance reaches its absolute minimum at the bottom of the curve, functional residual capacity. At this resting point, the opposing mechanical forces on the two vessel types are balanced. While the body uses chemical signals to route blood systemically, the lungs optimize flow through the passive physical mechanics of the respiratory cycle. When these regulatory mechanisms fail, the resulting loss of control leads to hemodynamic instability and organ failure. Pathologically high resistance can be triggered by chronic conditions like uncontrolled diabetes. High blood sugar causes non-enzymatic glycosylation of the basement membranes, stiffening the vessel walls and contributing to the formation of atheromas. Chronic hypertension creates a similar burden, remodeling both pulmonary and systemic vessel walls to be thicker and less compliant, which permanently increases the heart's workload. Conversely, distributive shock represents a pathological loss of resistance. In states like sepsis or anaphylaxis, massive cytokine release causes smooth muscle to go slack. Similarly, neurogenic shock involves a loss of sympathetic input, leading to dangerous systemic vasodilation. In both extremes, excessive constriction or total relaxation, the loss of dynamic resistance control prevents the body from effectively perfusing its vital organs. To manage these crises, clinicians use pharmacological agents to artificially manipulate the Tunica Media's contraction state. Vasopressors, such as epinephrine analogs, are used in distributive shock to agonize alpha receptors. This forces the smooth muscle to constrict, restoring the vessel tone and blood pressure necessary for survival. In hypertensive emergencies, calcium channel blockers like verapamil are used to relax the vasculature. By blocking the entry of calcium, these drugs prevent the formation of the calcium-calmodulin complexes required for smooth muscle contraction. Localized resistance can also be hacked using phosphodiesterase inhibitors like sildenafil. These raise local levels of cGMP and nitric oxide to force targeted vasodilation, providing a treatment for conditions such as erectile dysfunction. Successfully navigating these clinical scenarios requires tracing every pharmacological intervention back to its first principles on the vessel wall. We can now consolidate these concepts into a single working model. Prepare to pause and save these key summaries. This map unifies mean arterial pressure, the neural and hormonal drivers of systemic resistance, the lungs' mechanical U-curve, and the manipulating drugs. The most critical takeaway is the relationship between radius and resistance. Resistance changes according to the inverse fourth power of the radius, with the Tunica Media serving as the primary anatomical effector. In the pulmonary circuit, take note of the specific lung volume where resistance reaches its absolute minimum, functional residual capacity. For descriptive analysis, distinguish between the immediate neural control of the alpha-1 sympathetic pathway and the long-term systemic management provided by the RAS hormonal cascade. When evaluating the role of cGMP, be aware that while sildenafil primarily targets PDE5, some sources discuss PDE4 inhibition as a factor in vascular smooth muscle relaxation. Mastery of these microscopic variables provides the mechanical framework for managing hemodynamic stability in your clinical practice.